Welcome to this PCR Valves e-course TNT session on optimal TAVI outcomes in the active patients. The session objectives are to uncover the evolving needs of the active TAVI patients today, to discuss the hemodynamic needs in a patient with a small aortic annulus, and to demonstrate how to use the Cusp overlap technique to reduce conduction subnormality, but also to obtain commissural alignment, which is going to be discussed, the benefit of that. My name is Lars Søndergaard. I'm a cardiologist in Copenhagen in Denmark. And I'm pleased to be joined here by Didier Tchétché from Toulouse in France, Mohamed Abdel-Wahab from Leipzig in Germany, and by Darren Mylotte from Galway in Ireland. So before we start, maybe Didier, you can introduce the format of this TNT session.
Yeah, sure. Thank you very much, Lars. So these are very contemporary objectives. So to address these objectives, we're going to go through a recorded case that we're going to comment live. Feel free to be part of that live discussion by sending us your comments, questions, any thoughts that you have, and we will address them at the end of the session during the live chat. So be part of that session. We're going to address your comments at the end. So I guess we can start the recorded case.
From the Heart Center Leipzig in Germany. My name is Mohamed Abdel-Wahab. I'm an interventional cardiologist, and we're happy to present you a recorded live case today from our hybrid operating room. On my right-hand side, Philip Kiefer, who's a cardiac surgeon, and he's going to do the procedure with me. And also in the room, we have Vladimir from the anesthesia, Petra, Norbert, and Mike. And let's start by showing you a few slides about the case. So the session is on optimal outcome of TAVI in the active patient. And our patient today is a female patient. She's 77 years old. You can see here that she's a little bit overweight with a body mass index of around 30. She has some comorbidities. So she's hypertensive. She has a known diabetes mellitus. She's hyperlipidemic, and we talked about the overweight. And she also has some chronic renal insufficiency, which is probably secondary to her cardiovascular comorbidities. Her prior clinical history is relevant concerning a left-sided mastectomy followed by radiotherapy for breast cancer, which was almost 1 year ago. The patient luckily recovered very well from this operation, and she now presented to us with progressive shortness of breath, and she had one attack of syncope. Her laboratory investigations were overall unremarkable, so the hemoglobin level is normal. I remind you that this is in millimole per liter. Her creatinine a little bit elevated. We talked about the renal function. She has almost normal NT-proBNP, only slightly elevated, and a slightly elevated hemoglobin A1C. Otherwise, as previously mentioned, her laboratory values were unremarkable. This is her ECG, and you can see here that she has normal sinus rhythm, and she has narrow QRS complex with no bundle branch block. And on echocardiography, as you might expect, she has a clear high gradient aortic stenosis with a mean gradient of 48 millimeters of mercury, an effective orifice area of 0.9, no relative AR, and a normal LV function. The patient was diagnosed actually at an external hospital, and they did a coronary angiogram, and you can see here that she has some coronary artery disease, but no significant lesions. And this is her multi-slice CT. You can see here that she has rather favorable femoral access with the good size of the femoral and iliac vessels on both sides. And when we look at the valve itself, you can see here that the valve is more or less moderately calcified, a little bit asymmetric calcification on the non-coronary cusp. And she has overall a small anatomy. So we can see here the annular dimensions, the area of 335, a perimeter of 66.5. So the area and perimeter derived annular diameter is between 21 and 21.6. She had good distance to the coronary artery. So overall, a favorable anatomy for TAVR, despite the fact that this is considered a small anatomy. Interestingly, and this is something we still don't do routinely, but we do it in selective cases, and we did it for this case as well. You can see here the measurement of the membranous septum. So she has a very short membranous septum, just around 1 millimeter in length. The width is 9 millimeters, so a very short membranous septum, and we know, and we will discuss this, of course, carries high risk of permanent pacemaking afterwards. The risk scores, the traditional risk scores, STS and Euroscore 2, put this patient into the category of low risk. The patient has no frailty characteristics, so she is still an active patient. She's 77, has some comorbidities, but she's active, doing her household with no restrictions except for the shortness of breath she has. And to summarize, and maybe afterwards we go to the panel discussion, this is a 77-year-old low-risk active lady. She has a body mass index of 30. She has severe symptomatic AS, no significant coronary artery disease. And when it comes to her anatomical characteristics, she has a small aortic annulus. She has no adverse root features, but she has an extremely short membranous septum. And I think this is where we may stop for a while and discuss potential options and then return to the case.
So would be interesting, I think, to hear your thoughts about the case. I mean, we are seeing these cases now more often in our practice than in the past. So Didier, what do you think? Would this be a patient that would be a TAVI candidate in your practice? I mean, surgery is also an option. What are your thoughts?
So I agree, this is really the first point of discussion that we should have. If we only take the risk scores, we could think that this patient is at low risk, but in fact, when we integrate all the parameters of her past medical history and the anatomical features, I do believe that she is more an intermediate risk patient. So transcatheter transfemoral TAVI could be a good option for her. Keeping in mind that she had chest radiation therapy in the past, so surgery could be at risk. And moreover, it's a small anatomy. So if we go for surgery, there are some technical refinements, more aggressive surgery that would be required. So I would say TAVI if it was my patient. So if we go for TAVI, Darren, do you think that this patient has specific risks that we have to consider?
Yeah, I think you highlighted the low STS score, Didier, which would put her in a low risk group. And of course, when we consider that all of the patients pretty much in the low risk studies had transfemoral TAVI, we need to ensure that she indeed is a good transfemoral candidate and doesn't have any particular anatomical features that would render her more suitable to surgery. So she does have good transfemoral access. She doesn't have, for example, a very severely calcified LVOT, bicuspid aortic valve, narrow sinuses, and so forth. So I think that in this particular case, TAVI is a good fit, but it is important to make sure that we optimize the TAVI in this patient and get a really great result. We saw that her annulus is quite small, I think a perimeter of 26 and a perimeter derived diameter of approximately 21. And if we're going to keep this lady who is 76 and very active, Mohamed, I believe, we need to keep her active, and to do that, we need to make sure we have great valve hemodynamics. That usually means in that small anatomy that we take a supraannular valve. And of course, we've seen the recent scope 1 and scope 2 data, which would suggest that minimizing paravalvular leak is very important in that hypertrophied ventricle, and of course, avoiding a permanent pacemaker. We saw that short membranous septum length, so a high implant will be important for her. But nevertheless, even if the valve is in a couple of millimeters, we know that the membranous septum length is not the most, the greatest positive predictor for permanent pacemaker. So in my opinion, this is a transfemoral TAVI, a supraannular valve with Evolut Pro to ensure we get good hemodynamics, no paravalvular leak, and avoid a pacemaker at all costs.
Lars?
Any additional thoughts, Lars?
Yeah, I mean, it's, as you said, it's certainly important to try to avoid conduction subnormality. We know this is going to put the patient at risk for both mortality and also for rehospitalization for heart failure. And we've seen a move in many institutions from using this classical LAO projection to a Cusp overlap view, meaning that from your CT scan, you find the C-arm projection where the right and the left coronary cusp is overlapped. It's often in an REO caudal projection. And I think that the benefit of that projection is that you're going to elongate the left ventricular outflow tract and thereby have a better understanding how deep or how high are you with your implant during the procedure. And of course, we want to have a high implantation without the risk of a pop-out. So I think that would be wise in this patient with a short membranous septum to use the Cusp overlap technique. And also I think she's a quite young lady, 77 years of age, so she could have pretty long life expectancy. So Mohamed, are you going to take any particularly considerations about how to reassure that you can access these coronary arteries in the future?
Yeah, that is, I think, a very important point, and we learned that we can do this with, particularly with the supraannular Evolute platform, and we will show this, I hope, in the case. This was one of the considerations regarding valve choice. So it's the hemodynamics was one consideration. The second was to have a platform, or if we choose a platform with good hemodynamics such as Evolute, that we maintain access to the coronaries and try to achieve commissural alignment in order to be able to do a redo TAVI in the future if necessary. And the third thing would be, of course, to try to get out of the procedure without a pacemaker, although this could be very challenging, or is indeed very challenging if you have a very short septum. As Darren mentioned, there are other criteria, of course. She didn't have any of these ECG or anatomic criteria beside the very short septum, but nevertheless, I think we should respect this and try to maximize our efforts in order to prevent pacing, even in such a situation.
So, Mohamed, maybe you can just shortly explain what is commissural alignment.
So with commissural alignment, we mean, of course, that, surgeons did this in the past and are still doing this in all their procedures, that you have a one-to-one alignment of the neocommissures of the bioprosthetic valve to the native commissures. And what we recognized after doing thousands of TAVIs is that the alignment is actually, in TAVI patients, if you don't pay attention to that, is actually random. So almost half of the patients have any sort of moderate or severe alignment. And in around, I think, 20 to 30% of cases, you have complete malalignment and you have the commissural posts exactly in front of the coronaries. And this prevents access and could lead to problems with redo procedures. And what we do with the Evolute is that we introduce the delivery catheter at a certain position. You will see this in the live case, just putting the port at 3 o'clock. And then we have some markers on the system. We will see this in the case as well. We look at these markers during implantation, and if you pay attention to them, you have more than a 90% chance to get out of the procedure with a very good alignment.
That's great. So maybe we should go back to the case and see what you actually did, Mohamed.
Yeah.
So after we discussed the case, we would like to present you with our strategy. So as you can see here on this slide, we are planning a transfemoral TAVI, and we have chosen, because of the small anatomy, a supraannular self-expanding valve, which is in this case an Evolute 26 millimeter, and we opted for an Evolute R, Philip, because we didn't see a lot of calcium on the leaflets, not a lot of calcium on the LVOT. Would you like to comment on this?
No, I think this is a very perfect selection of a valve, and especially for the supraannular, I think we will end up with a nice hemodynamic result. So this is, I think, in this case, the best strategy.
Okay. The access is right-sided. We obtained access using ultrasound, And we have used pre-closure with 2 ProGlides, which was something we are doing now within a randomized trial at our center, comparing the suture and the plug-based devices. We opted for cerebral embolic protection, and our aim is a controlled implantation supported by the Cusp overlap view in order to optimize implantation depth. And we also attempt to achieve commissural alignment, and this is something we can discuss. She doesn't have coronary artery disease, but she's still rather young and active. So we would like to make sure that we maintain coronary access. And also considering his age, her age, I think it's important to consider the possibility of a redo procedure in the future, which could be a little bit more difficult with a self-expanding device. But if you have commissural alignment, maybe you can have more options. And this is also, I think, something we can discuss. What we did until now, and we can show you on the images we have taken. So the first thing we, after obtaining access, this is the placement of the Sentinel device. So nothing outside of the routine practice. This is the 3-cusp coplanar view, which is in her case an LAO with a little bit of caudal, I think. And then we have also the Cusp overlap view, what I personally like to call the non-coronary side view. But I mean, it's the same. You're looking here at the non-coronary cusp from the side view, and the right and the left cusp are overlapping. And this view we are going to use in order to optimize implantation depth. We're going to switch between views, but also for commissural alignment, which is something we want to demonstrate. We already crossed the valve. Valve crossing was more or less uneventful, and now we will proceed with placing a safari wire in the left ventricle. And Philip, would you like to comment on our discussion concerning predilatation?
Yeah, well, in this case, we decided not to do a predilatation because the calcification, as you can see here in the fluoroscopy, is not that excessive. So we're going for a straight implantation of the core valve and maybe end up with a post-dilatation. But in this case, we're not doing the pre-dilatation. And maybe I can add a little comment for what you've said so far. I think the alignment is also very interesting in these small anatomies, just to make sure that you get not that much stress on the leaflets, especially for those in this elliptical anatomy. And this is also a very positive side effect in this procedure here.
Yeah, I think it's an important point, and it's something that probably also needs further evaluation. I think I've seen recently a very nice study, I think, from the group of Raj Makar, looking at the impact of commissural alignment on valve thrombosis. I think it's not published yet, but it seems, as you mentioned, that it could have an impact not only on access, but also on leaflet function. Yeah. Okay, so we'll now take the valve. So we are using we had a 14 French sheath, and now we're switching to the delivery device.
Maybe just to finalize the discussion, we of course have discussed this patient in the heart team in our daily matter. Just to make sure whether she's really a transcatheter candidate or, of course, a surgical candidate. And as you have seen in the presentation before, there are a lot of things that have to be addressed for this patient, especially the breast cancer radiation of the thorax, and, of course, the creatinine level. And, of course, the 77 years old, and I think we clearly decided for a transcatheter procedure.
Small anatomy could be something that can favor TAVI, but there are also a lot of surgical options. We can discuss this, of course, as well. The short membranous septum could be, in my opinion, an argument for surgery, because I'm not sure whether we have total control in the case of a very short septum, as in her case. So we will do our best, but at the end of the day, we also need to anchor the device. So we'll not be able, and we're not aiming at implanting the device at 0.
Yes.
I think not even at 1. So we'll try to implant maybe at 2 or 3 millimeters. It's very important to consider implantation depth, but also in the context of the small anatomy coronary access, and anchoring. Yeah?
Absolutely.
So now just have a look here at the flush port, please. If you
Moving
can
camera.
see it, yeah, with the head camera. We have the flush port now at 3 o'clock. And we know that this flush port marks one of the C-tabs, which overlies the commissures. So if you see this on a graph, you will easily understand this. So these are the markers we have. If you go at 3 o'clock, then probably, as you can see here on fluoroscopy, in a normal anatomy, you will see here that the hat marker, if we go a little bit in LAO, open up the curve a little bit, the hat marker will be probably at the outer curve. You cannot see it here quite nicely, but you will see it when we cross the arch. So in this case, the hat marker is, as you can see here now, when we go at 12 o'clock, it's on the outer curve. We'll remain actually, despite this fact here in this case at 3 o'clock, cross the arch and see now where we will land. So we can see here that we are coming actually very nicely through the outer curve. So despite that the hat marker was not on the outer curve in the descending aorta, just by maintaining the 3 o'clock position, you usually obtain a very nice position in the ascending aorta, and this is actually what matters. Exactly. Okay. What we do here in this case, we then switch to the cusp overlap view, to the non-coronary side view. And you can see here, this is very nicely demonstrated here. In this case, I'll take a picture of that. And you can see here that in this view, the hat marker is located center front. So it's exactly in the middle. And this is actually a slight adaptation to the technique described by Tang et al., a little bit adapted to the patient anatomy. So if you are in the non-coronary cusp or non-coronary side view, cusp overlap view, if you are center front, probably you have a very even higher chance of commissural alignment than if you're not. Okay, so let's cross the valve here in this view. Okay. We have rather good coaxiality, so Philip is keeping the wire, helping me a little bit. Maybe a little bit of push on the wire, Philip, just to try to be a little bit more coaxial. Okay. And we'll start maybe implantation or unsheathing of the valve here at this position. We will pace Vladimir at 140 when I give you the signal. Okay. Yes, so we'll start here. No, I'll tell you. We are starting unsheathing now, but we'll still wait a little bit. Okay. So it's important here that what we usually do is that the first operator has both the delivery catheter and the wire, and the second operator is unsheathing. So I'm trying to come a little bit higher up, and then we'll open a little bit more. Okay, let's do an image here. We stop for a moment. Angebete, schuss. You can see here that the pigtail is not perfectly in place, so we still need to optimize this. So we have to get the pigtail down. We'll go a little bit inside. This helps us also to maintain or to have better alignment. Okay, and then we continue. Okay, we'll stop here and take a picture again. Schuss.
That looks good.
Yeah, I think it's fine. We are maybe at 2 millimeters. So let's start pacing here, please. 140. Okay, I'll film this and we'll do it very slowly. Okay, so we'll stop here. Stop pacing, please. So very controlled deployment, and let's see if we are fine or if we are a little bit too high or too low. Let's do an angiogram here.
That looks good.
So in this view, it looks good.
Yeah.
Of course, it's on the non-coronary side. We cannot really go much higher. No?
Yeah.
If you look at the ECG now, Probably she's now having like some sort of an intermittent left bundle branch block, but she's still in sinus rhythm. Yeah, so the bundle branch block has now gone.
Yeah.
So now she's still in sinus rhythm. But it's extremely important here that we go back to our other view, just check again the depth or the height on the left coronary side as well. Because we have a little bit of a parallax here. And you can see here, still we have parallax here on the left side, so let's try to adjust this a little bit. And maybe zoom a little bit on the valve. Yeah, a little bit more zoom.
No more zoom?
Yeah, so we're zooming a little bit. Try to get rid of this parallax in order to be able to adjust height. What do you think of that, Philip?
Well, from here it looks really good, to be honest with you. It's just like maximum of 2 to 3 millimeters below the annulus, and I think the position is really good.
Let's do a picture here again. Angio and choose.
So maybe we discuss a couple of points here before moving forward and releasing the valve. So Darren, what are your takes on the Cusp overlap view? You're a big proponent of that, I guess. Do you do it like we do? Do you switch between views, or are you just using the Cusp overlap view now?
No, Mohamed, we do exactly as you did it. Your procedure looks like one of ours. Maybe ours aren't quite as slick though. So we start in LAO to come around the arch to ensure that we have the commissural alignment with the hat marker on the outside of the aorta as we're traversing the arch. We then switch to the areocaudal cusp overlap view, and we go exactly where you went to the point of no return. And we use that to assess our depth. And I think in this case, you've probably got a depth of about 3.5 millimeters. But before we release, we switch over to the LAO projection to assess the height of the left coronary cusp. It's really important that when you do that you pretty much forget about the height of the non-coronary cusp and the height of the right coronary cusp, because they're now out of plane. So we check in the LAO caudal what is the height on the left, and also get ready for the release of the valve. We want to make sure we release the tension from the valve. So we also like to make sure that the delivery catheter is not pulled right up against the lesser curvature of the aorta. So we go into the procedure with 3 views: an LAO to cross the arch, areocaudal to implant, and a final release in LAO.
So what I liked really during your deployment was the stability of the device, and I think it's a combination of keeping the wire deep into the left ventricle, ensuring coaxiality by starting high and then repositioning the device at target. And this was really helped also by the fast pacing that you achieved. And I think this is one of the refinements in terms of procedural techniques that we applied for the self-expanding Evolute. Fast pacing around 120 or to 140 makes it more stable. So I really like your deployment, and I think the depth is perfect, and this is my opinion. Lars?
Yeah, I agree. I think you're sitting in around, as you said, around 3 millimeters below the aortic annulus in an REO projection, which is where you should be. You shouldn't go too high, particularly not if you've foreseen that you need to do a post-dilatation, because the stent frame may foreshorten and you get a pop out. And also, I mean, 3 millimeters is certainly acceptable. Don't try to optimize something which is already very good, because it can also involve complication to recapture too many times with this valve. So it can touch on the conduction system and introduce conduction abnormality, and also that can be debris from the valve if you fiddle around too much. So I think this is a perfect position for you.
So let's see what was the outcome and how you managed to keep the device at target.
Okay.
So still a bit of a parallax here. I mean, it's important, and you see that we are taking our time. It's important if you're going to implant high, that you make sure that you're not too high, correct? Because I mean, the advantages and the disadvantages of a high position, I think, are clear to everyone. And we want to make sure that we are at the correct depth. So let's take a picture here without an angiogram. Yeah, it looks better here. What do you think, Philip?
I think it's really good because we have no regurgitation seen in the root shot. We have a nice height, and we also have to keep in mind that we have the membranous septum. So going deeper may cause the problem of AV blockage.
Exactly. And the nice thing about her anatomy that we are also like aligned on both sides, so we're not deeper on the left or on the non side. Usually you get deeper on the left side if you have a very vertical anatomy. So it's not the case. So I think we're fine. So let's keep now we'll pull the wire a little bit before releasing this device. We'll start pacing again at 140, and Philip will start to release very slowly, and I'm controlling the catheter, as you can see, a little bit with a little bit of a push to centralize it, and we're doing it very, very softly. Pacing unbitter, yeah. And you see here that while I release, I like to go back to the LAO view, just to make sure I'm controlling my catheter. Just do it small and smooth. Okay.
Okay.
Yeah, so both are up now. I think we have stop pacing. I think we maintained a perfect height. What do you think, Philip?
Yeah. I think we come a bit up,
Maybe
slightly millimeter up.
Yeah.
But I think we're still in a very good position. As you can see, the hemodynamics probably, we have still with a wire in place, we still have a 60 diastole, and I think the valve is also good aligned.
Yeah. Okay, so let's close the delivery catheter now. You need to do this also perfectly, or like very meticulously taking care of the position of the nose cone, the position of the wire, just to prevent this from embolizing your device upon retrieval. Okay, so now we are getting back to our 14 French sheath. The ACT is fine, Vladimir? Okay. You're, as a surgeon, you do it like naturally, the alignment.
Yeah.
You don't know anything else.
Yeah.
But why didn't we think of this in the early days of TAVI? We were just happy that we're implanting the valves. We're not thinking about all this fancy stuff. No?
Yeah.
Remember the septum, commissural alignment, and so on.
Well, that's a very good point. I think when I remember the times when we started TAVI, there were so many other complications that we were facing, and we were really happy to get the patient really good out of the OR. So I think it's quite clear that we are facing now we have a standardized procedure, and we're doing very good in a very rapid way. Now we have to think about all the issues that are coming up in the future, especially for those that has to have re-interventions. And I think that's what we are right now, what we are facing and addressing.
Yes, that's correct. I totally agree. I mean, we're now treating patients that are younger, that have a longer life expectancy. The procedure is standardized, so we're thinking now about what matters beyond the procedure.
Exactly.
Yeah, that's correct. Okay, so we have good hemodynamics. Wir schreiben mal bitte. So we had good hemodynamics, as you can see here, so we have almost no gradient. We'll do a pullback now. Kann ich? Okay. And now let's do a root shot, just to check the regurgitation on our final position. And then we'll also check alignment, because we can do this by looking at the C-tabs after implantation. Tigi? Gib mal bitte 15, 15. 15, 15, okay. So we'll now do a root shot. Angio bitte und tschüss. Okay. So we have a very, I think it's a very minor trace of AR, maybe at the left coronary side. What do you think, Philip?
I would definitely leave it like this. It's very, very mild. We have a high risk of embolization during post-dilatation. And of course, the CoreValve has such nice radial forces. Just leave it there for a couple of minutes, and probably the regurgitation is even less or gone. Yeah. So I think this is not anything that will affect the patient in the future.
I think you're totally correct. I would accept it as well. You can see here, of course, if you look at the anatomy and how much of the sinus of Valsalva is now being occupied by this big stent. And this is, again, a very important point concerning coronary access. Exactly. So we've seen now recent data from the ReAccess trial that have shown that there are a couple of predictors which include the amount of oversizing related to the sinus of Valsalva. And this is something we cannot, I mean, we want perfect hemodynamics in her small anatomy. Yeah. On the other hand, we don't want to lose coronary access. And this is why I think in her particular scenario, commissural alignment would be very important. So let's check it again and go to the cusp overlap view.
Yeah. And another thing that always have to be mentioned is that the commissural alignment on the valve itself is on 26 millimeters. Yeah, so that means you would cover in almost, or a lot of cases, the coronary access, and that's why alignment is really, really crucial in this patient.
Exactly. I mean, it's double as high as the skirt.
Exactly.
Okay. So I'll do a picture here and I'll show you what I mean. So I think, at least fluoroscopically, we should have good commissural alignment here. This is, again, the cusp overlap or non-coronary side view. And you can see here that the C-tab is located on the right side of the monitor, which is exactly where the commissure between the right and the left coronary cusp should be in this view. So again, I do think that we could have a very nice commissural alignment in this case. If we go to the LAO view, you can also see here what has been shown in the study of Gilbert, Tang, that we have the C-tab located at the inner curve, which is also something that gives you a feeling that you probably have commissural alignment. You can, of course, check this afterwards using echo or using CT. But I think that we achieved here what we want concerning a very shallow implantation, concerning the very short membranous septum. If you can look at the ECG now, probably she has a left bundle branch block, but she doesn't have any sort of AV block. And I think we have a good commissural alignment. So I think we're done now with the valve implantation. So let's remove the sentinel device now and then close the femoral artery.
So Mohamed, great case. That looked like a fantastic outcome for your patient. Can you tell us a little bit about how did she do post-procedure? What did you do in terms of monitoring that left bundle branch block? What kind of hemodynamics she had, an echocardiographic follow-up, and how you plan to observe her going forward?
Yeah, Darren. So maybe the first thing I'd like to comment on, and we had some like minor AR. So usually we are more happy to have no AR at all. But I think in her particular case, we judged this to be very minor angiographically and hemodynamically. And this was actually also seen in her post-TAVI echocardiogram, where she just had a trace paravalvular leak. So I think we are very, we post-dilate a lot of patients just to get rid of AR completely, but in her case, we didn't think that this was necessary. And we thought that even post-dilatation may increase the risk of conduction abnormalities. So concerning hemodynamics in her small annulus, she had a fantastic gradient. So she had a mean gradient of 4 on her discharge echo with a valve area of 2.0 and an indexed valve area of 1.2. So far away from any mismatch. She did fine. She was kept in hospital. We keep patients in hospital in Germany, as you know, a little bit longer than in Denmark and in France. So she was discharged on day 3 post-procedure. She had a left bundle branch block at 140 milliseconds, which was persistent, but no forms of any AV block on telemetry. So we were fine with that. We were not concerned that something would happen after the 3 days, and she was doing fine.
Wow, that's a pretty impressive hemodynamic result. Lars, tell us, I mean, that kind of valve area of 2.0, that's got to really tie into long-term durability of these prostheses, right?
I guess so, Darren. I mean, and as we're moving to these patients with longer life expectancy, durability is becoming a real issue and something we need to take into consideration, particularly in patients like this one with smaller aortic annulus. And what we've seen from the Notion trial with the CoreValve platform is that at 6 years, it's actually having a very high durability and low failure rate. Whereas if you look into the Partner 2 trial with the Sapien platform, which is offering smaller opening area, it seems to be equal to the surgical valves.
And Didier, in particular with these smaller patients, this has been an open question, whether supraannular prostheses provide better durability, better quality of life, better exercise capacity. And all of this is relevant to this 76-year-old active lady. You're heading up a prospective study looking at this particular topic. Can you maybe give us a few pointers on what we can expect from this study?
Yeah, sure. And that's why I really enjoyed that case, because it perfectly depicts the type of patient that we're going to include in the SMART trial. The SMART trial is going to be a randomized trial that is going to compare in patients with small annuli a balloon expandable platform to the Evolut platform, the Evolut Pro and Pro Plus. So we're going to understand better about the hemodynamic performances of these platforms in this particular group of patients, because we know that potentially TAVI is favorable, is preferred for this small annuli population, but we still don't know what is the best platforms for these patients. We've seen through the case that potentially a supraannular self-expanding platforms works better with larger EOS, lower gradients, but we need a randomized trial to address that. It's going to be the case with SMART, all-comers population, including bicuspid patients, but also valve-in-valve sub-cohort of patients. So really, it's going to be a massive trial, extremely exciting, that is going to impact our daily practice. So we're looking forward to it.
Yeah, us too. I think it's very important to get that information. Lars, I think we've got to the point where we can get onto the chat and discuss with the participants some of their questions. So maybe I might hand over to you to lead us through some of those questions from the participants.
Yeah, that's great, Dan. And if you have any questions, there's still a chance to send it via the chat function, and we're going to address them now.
Stay with us.
So, Darren, I can see there's been quite a few questions about this Cusp overlap view, and I'm not sure everyone know what this actually mean, and what does it mean in the cath lab, and what is the potential benefit of it? Maybe you can just explain it very simple for people who's not into Cusp overlap view.
Sure, Lars. So you can get the aortic valve annulus in plane in many different orientations. You can get it in plane in an iliocranial, you can get it in an AP usually, and you can get it in an areocaudal. And you can implant the valve, therefore, in any of those projections. But because there's an angle at the LVOT as it enters the aorta, you can get some foreshortening of the aortic root in some of those angles. And therefore, to elongate the LVOT, to really understand your true depth of implantation, you need to be able to elongate the LVOT to have the maximum diameter between, for example, the pigtail and the bottom of your delivery catheter or the bottom of your valve frame. And you get that maximal elongation of the LVOT in about 85–90% of people in an areocaudal projection. Now, in areocaudal, you also happen to overlap the left and non-cusp, therefore, the left and right cusp, therefore isolating the non-coronary cusp. And so when you're planning your procedure, if you can overlap the left and right cusp using 3Mensio or whatever software you use, that tends to occur in an areocaudal. And if you implant in that areocaudal position, you really understand your depth of implant. If you're over an LAO, you tend to think that you're higher than you actually are. And so your true depth is deeper. On the other hand, in the areocaudal, your true depth tends to be your true depth. And so if you want to be at 3 millimeters, chances are you're going to be at 3 millimeters.
So this is a projection you decide pre-procedure, looking at your CT scan before you go into the cath lab.
Yeah, absolutely. So most CT softwares at this stage give you an S curve, and on that S curve you can follow the S curve from eleocranial all the way down to the bottom of your screen to areocaudal. And if you pick pretty much any of those areocaudals, you don't need to go really steep areocaudal. Even if you pick a relatively shallow areocaudal, it's going to give you a cusp overlap view. It's going to give you a really good understanding of your implant depth. And there are some other additional benefits from implanting an areocaudal. Well, your RAO, so you understand where your wire is in the left ventricle. You saw that Mohamed was pushing on the wire to keep himself nice and high. The valve usually looks very straight. It looks nice and vertical. And one of the other important advantages is that that's the short axis of the aortic valve. And so if your valve is mal-expanded, you're going to see it better in that view than if you're, for example, in an LAO view. So for us, we, as Mohamed showed us, we come around the arch, we go to that areocaudal or cusp overlap view and implant there to assess our depth.
So this is a technique which is all about try to minimize the risk of conductance abnormality, a new permanent pacemaker.
Yeah, exactly.
So then, is there anything you need to look out for? What is any potential risk of using this projection instead of the classical LAO projection?
Yeah, that's a good question. And most people are very comfortable, or a lot of people have become very comfortable implanting in the LAO. And to my mind, there are really two issues that can arise with the areocaudal. Sometimes you get a very steep areocaudal, or you get an obese patient, and you really can't see where you're implanting. And in that situation, don't use this view. Just come maybe a lot more shallow on your caudal and there, or if your view is bad, just go to a traditional LAO. The second issue, Lars, is that sometimes you're not sure how much push or pull that you have on the delivery catheter. And therefore, like Mohamed did again, switching over to the LAO to release the valve is very often a good idea to make sure that you don't have that delivery catheter pulled onto the lesser curvature of the aorta. But to my mind, they're really the issues in terms of switching from the traditional LAO implanting view to the RAO implanting view. I don't think that you're implanting higher, you're intentionally implanting higher in this view. I think you're still implanting at a 3 millimeter depth, which is what we've been advised to do. I don't think you should try and get 1 or 2 millimeters in this view. Just go for 3 millimeters, but do it in the areocaudal, because that really means that you will be 3 millimeters.
Mohamed, another question which has been in the chat I can see here during the presentation is this commissural alignment. Maybe you can, for people who hasn't thought about commissural alignment, what does it actually mean to have commissural alignment, and what does it mean to have commissural misalignment?
Yeah, I think the problem is we didn't think about this in the past. So the surgeons, they always did align their valves to the native commissures, which mean that the neo commissures were like placed at the correct site of the native commissures. And by doing this, you avoid overlap between the neo commissures and the coronary arteries in the majority of cases. There are, of course, some exceptions when the coronaries, when you have coronary anomalies, for example, or in bicuspid cases, you may have eccentric origin of the ostia, and even surgeons in these situations cannot do a perfect commissural alignment. But what we did in the past in TAVI, we just were implanting the valves at random. And what we've seen in some important CT studies is that in almost half of the patients, we have some sort of overlap between the commissures and the coronaries. This can be defined, of course, very meticulously by measuring the exact degree of overlap. But if you take this in totality, then you have in almost 40 to 50% of cases some sort of an overlap. Is this problematic? I think it's obvious that this is problematic if we want to obtain coronary access, because then you have the commissure in front of the coronary artery and you can have problems with accessing the arteries. I think this is a sound way of trying to interpret this. It could be problematic in future redo procedures. because, as you know, in future procedures, particularly with long devices, we may have a problem with deflecting the very tall supraannular leaflets of these devices toward the coronaries or even toward the STJ. And we have solutions for this, for example, by doing leaflet laceration with basilica. But obviously, you cannot do this if the commissural tab is overlying the ostia. Then basilica will probably not function adequately. And there are some other like physiological considerations regarding leaflet coaptation and regarding also long-term leaflet durability, but they are not proven yet that they can be affected by commissural alignment. And this is why currently we are thinking of trying to align similar to surgeons and avoid overlap between commissures and the coronary arteries. By some modifications of technique, this is not perfect yet, because the valves and delivery catheters have not been designed incorporating certain markers or options in order to help us. So we're trying to overcome this, but it seems to be possible in a good percentage of patients, particularly with the Evolute device and probably also with the Accurate and Portico. There are some studies coming up, but it's not like that with the balloon expandable device yet.
So, of course, particularly with the Evolute platform, where you have a supraannular position of the leaflets, it's maybe even more important to have commissural alignment. You showed it during your live case, but maybe just once again, just repeat, what did you do to get commissural alignment with the Evolute platform?
Okay, so this is actually work that has been done by your group and the group of Gilbert Tang, where we, by just adapting the technique or modifying the implantation technique of the Evolute device a little bit, you can increase the percentage of patients that get commissural alignment from maybe 50-60% to around 85%. And this is simply by making this flush port of the delivery catheter looking at 3 o'clock rather than 12 o'clock, what we were doing in the past. And then you probably have to check, or what you do during the procedure, you check the hat marker, which is at 90 degrees to this flush port, that it is on the outer curve of the thoracic aorta. And if it's in the outer curve in the LAO position, this is what have been shown in your study, then you have a higher chance of getting commissural alignment. What we are trying to check is if you can modify this a little bit and make it a little bit more patient-specific. And this has been shown in this case, and I think your group is working on that as well. By changing or by looking at the hat marker in the cusp overlap view, you actually can modify your implantation technique a little bit to even hopefully obtain commissural alignment in a larger percentage of patients. This is something that we need to prove yet, I guess. But just to make this rather simple, just change to 3 o'clock, track the hat marker at the outer curve, and then you automatically increase the percentage of patients that have good alignment significantly. And the rest is something that we are still working on.
Yeah. So the simple message is, if you just want to introduce the delivery system with the flush port 3 o'clock, meaning it's pointing towards the patient's left side, when you introduce it, you have a much higher chance to get commissural alignment. Gigi, there's also been some questions about patient prosthesis mismatch. What does that mean for the patient's outcome? Do we have any data that is going to affect durability or mortality for the patient if you have patient's prosthesis mismatch after TAVI?
So Lars, this is a very important question, because when we think about offering TAVI to younger patients, we have to think about that. What we know mainly derives from the surgical literature. What we know is that after a surgical aortic valve replacement, if you have moderate or severe patient prosthesis mismatch, this is going to impact the survival up to 10 years. So this is a true outcome that we should avoid. When it comes to transcatheter aortic valve implantations, if we are refer to the STS-TVT ACC database with more than 60,000 patients, we could see that severe PPM was associated to an increased mortality after TAVI. So it seems to have some kind of clinical impact, and mortality is the worst outcome that we try to prevent for our patients. So this is something that we should prevent. The main factors for severe PPM are first the valve-in-valve procedure and also the small annuli, small anatomies, and this is something that is concordant all across several studies. In terms of functional assessment, functional status of the patient, when you have a severe PPM, this is going to impact your exertional ability. So the gradients are going to increase furthermore on exertion, and you're going to have more shortness of breath and so on. So impact on quality of life and exercise tolerance, but most importantly, potential impact on survival. So this is something that we should prevent, and it paves the way for the SMART trial, as I said before. And the SMART trial is going to focus only on small annuli in native anatomies. After further discussion, we decided not to include valve-in-valve, but we have enough patients with small annuli that will need to be treated. And we're going to see if a self-expanding supraannular platform is going to perform better. We think it's going to be the case as compared to an intra-annular device. So PPM, severe PPM, we should treat it, prevent it. We're going to see what is the best platform to achieve that.
Dan, there's also been some questions about conductance abnormality. I mean, there's no doubt if the patient had a 3rd-degree AV block, you need to put a permanent pacemaker in. But what if the patient have a new onset left bundle branch block? How to handle that? And or do we need to take anything into consideration? Can we just disregard it?
I think it depends, Lars, to a certain extent on the individual patient, and probably their short-term and long-term management strategies. I think in terms of the short-term, if the patient develops a new left bundle branch block in the cath lab during the procedure, but has not had any further higher degree of AV block, does not have a new 1st-degree block during the procedure, and the QRS duration is under 145 milliseconds, in that situation, we tend to take the temporary wire out, we tend to take the sheath out and let the patient go back for of course, close monitoring. But in that situation, really, the chances of the patient developing higher degrees of AV block is very slim. On the other hand, if the patient develops a new left bundle branch block that is longer than 145 milliseconds, then they're at higher risk over the next 24 to 48 hours of developing higher degrees of AV block. And in that situation, we would probably keep the temporary pacer in place for 24 hours and see how things progress. So in terms of the short term, I think 2 important messages for the community. First is 145 milliseconds. If it's less than that, you can take all the gear out on the table. If it's longer than that, then you need to monitor the patient. Second then is that before you discharge the patient with a left bundle branch block, you need to make sure that that left bundle branch block duration, that QRS duration, is stable for 24 hours. If it's getting a little bit longer, then you have to continue to monitor the patient until it's stable for 24 hours. If, on the other hand, you come in the following day, it's got even shorter, the patient can probably go home at that point. So short-term management strategy, I think, depends on the QRS duration. In the longer term, we don't know that QRS duration or the development of a new left bundle branch block impacts mortality. It may have an impact on LV dysfunction, but to date hasn't been proven to impact mortality or patient symptoms. So you best avoid it if you can. How do we do that? The standard things for conduction disturbance: high implant of the valve in an areocaudal position. Try and minimize pre and post dilatation, and of course, the other tenets of avoiding pacemaker in terms of excess oversizing to be avoided, etc.
That's great. So I think we're getting close to the end of this session. So Didier, I don't know whether you want to summarize and conclude it.
I think this was an excellent session, and we clearly understand how important is the analysis of the anatomy of the patient and understanding what are the challenges. And here the hemodynamics were part of the decision making for this particular patient, and understand how the selection, the platform selection, is going to impact that, and how we have to understand the techniques, know the techniques, and apply the proper rules to get an outcome as good as we saw for this lady. So I'm going to tell that if you want to get more insights, more tips and tricks about how to deploy the Evolute platform, just go on the channel 3 tomorrow, learning the fundamentals. You're going to get everything, many tips and tricks on how to properly deploy the Evolute Pro platform. So I would like to thank you. You are always looking good on screen, and it's good to see you. It was nice to chat with all of you, and I wish to see you soon in person. Bye-bye.
Thanks.
See you guys.